Welcome to the next screencast. This screencast is about classification and treatment plans. If you look at this building in the background, this was a state hospital in Traverse City, Michigan. Actually, my great-grandmother worked there for a period of time. Unfortunately, this state hospital has been closed, but now it is actually luxury condominiums. So here today what we're going to be talking about is really the classification of different disorders, and we're going to just go really briefly into treatment plans. A lot of the work today will be vocabulary, so you'll be learning a number of new words, but they're very important. So the first thing that we talk about is client and clinician. Now, a lot of people would think that a psychological, somebody that's receiving psychological services would be called a patient, but the American Psychological Association recommends using the term client. It breaks down the doctor-patient dynamic in a good way according to the APA. So it's not like you have an authoritative figure and someone that needs to be healed. It implies a collaborative working environment. Now, anyone that's providing psychological services, and there's going to be a lot of different service providers, the generic term is clinician. Now, I am a psychologist. I'm a licensed psychologist in the state of Wyoming, and people oftentimes get confused about what a psychologist actually is. So a psychologist is a healthcare professional that offers psychological services. And those are typically broken into testing, therapy, and consultation. The client would be anybody seeking those services. So again, that term client is more collaborative. Patient carries with it the connotation of passive rather than active participation in the treatment process. Now, a psychiatrist, and let me say that again, psychiatrist versus psychologist, very, very different degrees. So psychiatrists go to regular old medical school, and then after medical school they specialize their training in psychiatry, which is predominantly prescribing medication. So they receive specialized training in diagnosis and treating people with psychological disorders. They might do some little therapy here and there, but predominantly medication oriented. Whereas a clinical psychologist, we also go to grad school. We go to a doctoral program as well, but the degrees are going to be different. So we focus just on psychology, and we're trained in all sorts of the behavioral sciences in general, but in therapy and assessment and consultation. So there's actually two types of doctorates in psychology. One would be a PhD, and the other is a PsyD. The PhD is a Doctor of Philosophy. That's what I have. And a PsyD is a Doctor of Psychology. Now, really, what we're talking about is a PhD would be like a scientist practitioner. So a PhD is trained more in science, in research methodology. Typically, you have to complete a dissertation doing original research. Whereas a PsyD would be a practitioner that's informed by science. So they focus more on providing direct services to clients. If you're interested in this field and you just want to work with people, you probably want to look at a PsyD degree. But if you are like me and you want to work with people, do research, and teach, a PhD is a preferable degree. Right there, there's a copy of my PhD if you ever wanted to check it out. Now, some terms that we have to cover that are research terms, but they're applicable to assessment of disorders and diagnosis are reliability and validity. Now, if you're a student of mine, you remember my little trick for reliability and validity with the bathroom scale. So reliability, I want you to think of one word, and that's consistency. If you get on a bathroom scale, you're going to have a consistent score every time you're on it. Validity, I want you to think of one word, and that's accuracy. And so in assessment and diagnosis, we use reliability and validity. We need our diagnoses to be reliable and valid, our assessment measures as well. We talked about the DSM in the last screencast, but we'll cover it again here really quick. This is, again, published by the American Psychiatric Association, not the American Psychological Association. So this is primarily psychiatrists or MDs that put the book together. However, a number of psychologists do consult on the writing of the DSM. And the DSM has a 5-axis system. And the axis system allows you to really formulate the case in that biopsychosocial model that we talked about last time. Now, you know that this is a DSM-4, but the DSM-5 is here. It just arrived. I honestly don't even have a copy yet. One, because it's incredibly expensive. It's like close to $200. So I'll be getting my copy here shortly, but it just went on sale, I think 2 days ago, which would be May 21st of 2013. There's some changes to the DSM that we'll address throughout the class that will appear in DSM-5. I'm not happy about a lot of them, as are a lot of other folks. So we'll address that in the class. That's what the DSM-5 cover will look like. And that multi-axial system, again, we'll go back to that because it's very important. And what it is it's a classification and diagnostic system that summarizes a variety of information about the individual's physical and psychological functioning. It also indicates stressors. It's good. So here's what the axes are. So axis 1 are clinical disorders like anxiety, depression, schizophrenia, ADHD, bipolar disorder. Axis 2 is reserved for personality disorders. You will know a personality disorder diagnosis because it will say personality disorder in the title, like borderline personality disorder or antisocial personality disorder. And then mental retardation is on axis 2. Actually, in DSM-5, mental retardation the name is going to change. So that term will become outdated. We'll talk about that in later chapters. Axis 3 are general medical conditions. Axis 4 are psychosocial and environmental problems like legal problems, homelessness, poverty, lack of social support, contact with the criminal justice system like arrest, probation, parole. And then Axis 5 is something called the Global Assessment of Functioning, or GAF, GAF scale. And this is a scale from 0 to 100 that assigns a score of how that individual is functioning at that time. 0 being good, 0 being terrible, 100 being perfect. Here's some examples of disorders. The diagnosis over here. These would all be Axis 1 disorders that some are diagnosed in early childhood, others throughout later in life, like dementia or early adulthood, with schizophrenia. There's a number of other disorders. I'm not going to take the time to go through these because basically what we do in this class is we go from category to category to category and we discuss the diagnoses within that category. But these are all Axis 1 disorders. Here's an example of psychosocial problems that we diagnose on Axis 4. You can see those. Here's the GAF scale. So if somebody is in the 1 to 20 range, they're going to likely, well, hopefully they'll be hospitalized. But someone up in the 80 to 90 range, they'll have no or minimal symptoms. All right, one thing I do want to address are culture-bound syndromes. And I want you to read about these in the textbook, but also Google them. So culture-bound syndromes are patterns of abnormal behavior or experience that are limited to specific societies or cultural areas. Here's a list of different culture-bound syndromes. And we're not going to go through these specifically, but they happen in one specific population. So like Arctic hysteria in Alaskan natives is this abrupt dissociative experience accompanied by extreme excitement and frequently followed by convulsive seizures or coma. Different disorders in different cultures. This one, Koro in Malaysia, is kind of interesting. Why don't you read that one? There's another classification of manual called the ICD-10, and this is the International Classification of Diseases. There's also classification of mental and behavior disorders within there. It pretty much overlaps with the DSM. And this is what mental health professionals outside of the United States and Canada use to diagnose disorders. So what happens in the diagnostic process? Well, first off, somebody will have a principal diagnosis, and that is the disorder that is considered to be the primary reason that the individual is seeking professional help. Now, there might be a secondary diagnosis or a comorbid diagnosis. Make sure you know that term, comorbid. And that occurs when multiple diagnostic conditions occur simultaneously within the same individual. So you might have multiple secondary disorders. Sometimes it's difficult to determine what's a principal diagnosis and a secondary diagnosis. And then there is a process that we go through called differential diagnosis, where we systematically rule out alternative diagnoses, and we do something that's called a case formulation, where we conceptualize the disorder from the various psychological perspectives. There's also a cultural formulation. You have to be very culturally sensitive to others' cultures, and we would look at the degree of identification with the culture of origin, the culture's beliefs about psychological disorders, and the way in which the culture interprets particular events, and the cultural supports that are available to the client. So if you are in Wyoming, you might maybe potentially would have like a Native American client. You would want to do a cultural formulation of the disorder to see if it's culturally normal or appropriate. The next thing that we do is planning the treatment. And what treatment plans do is they outline how therapy should take place. It would include the goals of treatment. So, you're not just going to treatment forever and ever and ever. The goal of treatment might be a 50% reduction in depression symptoms. Or maybe somebody has a fear of flying, and so maybe the goal is to be able to fly on an airplane. You might have immediate goals or short-term goals and then long-term goals. Once those goals are met, that would signal the end of treatment. There's all sorts of different treatment sites, from hospitalization. Sometimes people have to be hospitalized. In Wyoming, we call that Title 25. That's typically reserved for people that are, that I should say, this is involuntary hospitalization. So you're hospitalized against your will. And here we reserve that for people that are mentally ill and dangerous to themselves or dangerous to other people. Basically, they're suicidal or homicidal. You can be voluntarily hospitalized too. A lot of people choose that treatment option. There's a state hospital in Evanston, Wyoming. There's specialized inpatient treatment centers. That would be quite common. Like, for example, inpatient drug treatment centers are frequently affiliated with hospitals or other organizations. Sometimes they're standalone facilities. There's outpatient treatment centers where people would just go for an hour of treatment, maybe once a week. There would be different arrangements for different clients. There are halfway houses and day treatment programs. Halfway houses, people are transitioning out of a hospital into the community, and they would live in a structured facility. Day treatment programs, individuals show up for the day, but they live in the community. The day time activities would include different treatments. It's pretty common with people that have cognitive impairment or dementia. There's also substance abuse day treatment programs. And there's a number of other sites as well. So there's lots of different levels of treatment. You want to match the appropriate level of treatment for the appropriate disorder. This is South Florida State Hospital. This is a hospital that I worked at as an intern. I was doing a psychopharmacology postdoc program. So I was here for quite a bit of time. It really was a beautiful facility. One interesting note is that South Florida State Hospital is run by a private company that the state of Florida contracts with, called GeoCare, which is actually in the corrections industry. I'm not exactly sure how I feel about that, but that is a movement in state hospitals to contract out with private for-profit corporations. This is a state hospital in Wyoming, which is in Evanston. It's a new facility. It's quite nice. There's lots of different modalities in which treatment may be offered, from individual therapy, where you and like a client and a clinician would sit together. Typically, it's in a room, a closed room. So there's privacy, so confidentiality can be maintained for about 45 minutes to an hour. There's family therapy or group therapy. One thing that I want to really stress here is evidence-based practice in psychology. If you're doing therapy with a client, you should really try and strive to do a therapy that has been supported through research, not just something that you come up with on your own. So we want to make clinical decisions that integrate the best available research evidence and clinical expertise in the context of the cultural background, preferences, and characteristics of the client. So we want to meet them where they are culturally. However, you want to practice from a research-based, evidence-based practice. There's different ways that treatment is implemented. There's various courses of treatment depending on the disorder. It might be relatively short-term or long-term. The clinician's role can vary in treatment based on the training of that individual and the theoretical perspective that they use. So they can be very active in treatment or more passive. The client's role can change. The client may be very active, And the outcome of treatment or the goals of treatment might be radically different based on the client. So that's the end of this Prezi. I hope this gives you a good introduction into treatment and classification of disorders. Read your book to get further information on this. Let me know if you have any questions.